In our experience, athletic groin pain is primarily a load issue. When we use the term load, we mean the time spent running, jumping, twisting and turning in an athletic setting. This may not necessarily just be game time, it can be training time, sometimes it can be recreation time, and it's a cumulative effect where weight spread through the feet, the lower limbs is transferred across the groin and can lead to an overload syndrome. As such, players who train and play a lot are more prone to injury than those who do not. We've seen, for example, a pattern where in Gaelic football we tend to see more groin injury than we do in hurling, because our estimation is that Gaelic footballers probably cover more ground over the course of a game due to the nature of the sport in comparison to hurling, where traditionally the ball is let to do the work. Existing injury is also a big factor in the development of athletic groin pain. Injury in and around the hip flexor, the hip joint, the gluteal muscle, the adductors themselves, or the rectus abdominis, that's the six-pack muscle, all of which insert into the pubic bone. Injuries to these areas may predispose to groin injury. Similarly, problems around the knee and ankle may alter gait and as a result disimprove or increase the amount of force through the joint and ultimately through the pubic symphysis, changing load pattern and causing injury. Structural issues such as femoroacetabular impingement of the hip, problems with the pubic symphysis itself, such as in women loosening of the pubic ligaments after pregnancy, are all issues which may predispose the athlete to groin pain as well. And in our setting we would also see a good deal of acute injury. This is injury where on a twist or a turn, a powerful kick or forced abduction of the leg, this is where the leg is moved away from the center of the body, such as forced splits, we can see acute injury to the adductor muscles or the rectus abdominis muscles on the front of the groin. Similarly, a heavy fall onto the knee may transfer force superiorly or towards the head, putting a lot of pressure to the superior hip joint and causing labral tears. Typically, we break the structures involved in groin pain into the anterior groin, the hip, and medical pathologies causing groin pain. In the anterior groin, the major players would be the rectus abdominis muscle, that's the six-pack muscle which inserts at the upper aspect of the pubic symphysis, the adductor longus muscle which has a conjoined aponeurosis with the rectus abdominis muscle. This means that both muscles share a common insertion into the bone. This is extremely important in terms of the developing of pathology, as injury to the adductor muscle, which is essentially a leg muscle, the muscle we use in kicking a ball across the body, can also cause pain along the side of the rectus abdominis or six-pack muscle, a very confusing symptom that patients often experience. The other structure very close to this area would be the pubic symphysis itself. This is the meeting of the two pubic bones, which are separated by a disc of cartilage called the pubic symphysis. This can be a site of pain when there is excessive load across the area. Load, as we discussed earlier, is an excessive amount of training or playing which causes force to be transferred from the feet across the pubic symphysis. Just above and lateral to the pubic symphysis, we find the internal and external oblique aponeuroses. These are broad attachments of the wide sling-like muscles which come across the side of the stomach and allow us to do activities such as an oblique sit-up or crunch. These muscles are quite often injured. They gain an awful lot of focus as they are the area that is often repaired in a Gilmore's groin operation. However, in terms of the major pathologies in the area, these are probably less frequent than would have been previously thought. When we move on from the anterior groin, we see the hip structures which can be involved. The hip itself, of course, can have wear and tear such as osteoarthritis. However, much more common in a younger athletic population would be the presence of what's called femoroacetabular impingement. Much debate surrounds this area where it's thought that it may in fact be a normal anatomic variant. This is the medical name for a condition which exists when the shape of the femoral head, this is the ball at the top of the main leg bone, is incongruous or not the correct shape in comparison to the socket, which is called the acetabulum. One impinges on the other, therefore we get the term femoroacetabular impingement. This is often argued as being a normal anatomical variant. However, in our studies we have shown that this condition in particular can lead to a loss of internal rotation. That's movement of the femur on the acetabulum, and a loss of internal rotation is a major player in increasing the forces across the anterior groin and causing groin pain. When we speak of the hip, we also speak about the hip flexor. This is a large muscle which arises in the lower 5 lumbar vertebrae, crosses out of the pelvis underneath the inguinal ligament and inserts at the lesser trochanter. This is often seen as being a pathological structure in groin pain, in that it's most often painful and limits activity in the person with an athletic groin. The reason being that if the hip is irritated, the hip flexor passes in very close proximity to this, and it is in turn irritated in its own right. When it has been irritated and painful for a while, we often see that the area becomes tight and weak, and patients with athletic groin pain will often have a good deal of hip flexor weakness and dysfunction. It may, however, in its own right be a primary cause for the pain. This, in our experience, is less common than reported. When we talk about medical structures involved in groin pain, we look at usually remote structures which may refer to the groin. High lumbar discs, such as at the L1, L2 level, can refer to the anterior groin and upper lower limb areas, which would sometimes mimic groin pain. Likewise, the sacroiliac joint, which is the junction of the pelvis and the lumbar spine, can in its own right cause pain across the front of the groin and mimic so-called athletic groin pain. Other inflammatory conditions such as ankylosing spondylitis or rheumatoid arthritis may rarely cause inflammation of the pubic symphysis across the area. In our experience, the first step in the correct treatment of athletic groin pain is securing a correct, accurate diagnosis. Because of the close proximity of many of the pathological structures or pain-causing structures in the area, we need to be very careful that we don't take a one-size-fits-all approach either to the diagnosis or rehabilitation of this problem. Therefore, securing an accurate clinical and subsequently radiological diagnosis is absolutely crucial. Taking a close history and examining the patient carefully will often localize the painful structure. In our practice, we would use 3 Tesla magnet MRI to confirm this diagnosis. Specific protocols aimed at visualizing the pubic symphysis and pubic aponeurosis make the diagnosis of pathologies such as pubic aponeurosis injury. This is the combined insertion of the rectus abdominis and adductor longus tendons. Very easy in comparison to extremely easy in comparison to conventional imaging, and from our perspective are an invaluable aid to making the correct diagnosis. Once the correct diagnosis has been made, it's possible to generate a personalised, injury-specific rehab protocol based on what your needs are, both in terms of recovering from your injury and getting back to your pre-injury level of activity in whatever your desired sport is. When a correct diagnosis has been made, it's very important that the appropriate rehabilitation is arranged for the athlete to address their problem. For example, if your main issue is a rotational deficit, this is the ability for you to twist and turn while maintaining good form and control. If this is the major problem, unless it's part of your rehabilitation program, in the initial stages your acute symptoms may settle down. However, when you get back into your sport, which involves twisting or turning, you're highly likely to break down again and have a recurrence of your symptoms. As such, your treatment has to reflect your problem, and you have to have arrived at the correct problem in the first place. Similarly, you may have been instructed on the correct rehabilitation but may not be performing this rehabilitation properly. In our experience, there's often very poor carryover between instruction and completion of rehabilitation tasks. To this end, we provide video feedback on rehabilitation exercises, which the athlete can see live at the time, but also access at home while they're completing their program. This reinforces the message with regard to the movement patterns we are trying to attain and improves patient completion. Osteitis pubis is in fact a term used to describe an infection of the pubic symphysis. This often occurs after either an intervention to the pubic symphysis or gynecological surgery. Therefore, in reality, it's an extremely rare occurrence, despite the fact that it's referred to regularly in terms of an athletic population. One of the reasons for this is that on MRI, the pubic bone stress injury which is seen in this condition quite often mimics an infective process, though we know that this is not in fact at the root of the problem. This is similar to stress reactions in other parts of the body, such as in the bones of the foot, where we see stress fractures in runners. Pubic bone stress injury, as it is more appropriately called, is therefore a stress reaction in the pubic bone, usually caused by excessive movement at the pubic symphysis or excessive load through the pubic symphysis due to increased ground reaction force. We've introduced two concepts right there. The first being that when the pubic symphysis itself has to move more than it should, such as if the hips are tight or gluteal or hip flexor function isn't optimal, the pubic symphysis moves more than it should and becomes irritated, and a stress reaction is seen across the joint itself. This manifests itself as pain, usually after activity in the next morning, which is deep set and is aggravated by most activities where the abdominal or adductor muscles are used. Stress reaction secondary to overload is usually seen when the ground reaction force is increased. The ground reaction force is the pressure which is elicited through the foot and leg on striking the ground. We see this in groin pathology such as a tight hip flexor or abnormal gluteal function. When this occurs, excessive force is spread through the pubic symphysis and loads the area, leading to a stress reaction which, if it proceeds and the athlete doesn't listen to his symptoms, may convert to an overt stress fracture. As such, in the past, patients have often had ongoing symptoms for quite a long time, and the advice has been that they take 6 to 12 months off and allow things to settle completely. This is contrary to advice in any other condition that we're aware of in the body. No fracture takes this long to settle fully. It's a good idea, therefore, to progress through your journey through pubic bone stress injury pain-free. Quite often we will use an intervention to create a pain-free environment for the patient, such as an injection of the pubic symphysis or the pubic aponeurosis. And once the athlete is pain-free, they progress through their rehabilitation at all times, avoiding activities which are aggravating or recreate their pain. Surgery for groin pain is a reasonably controversial topic. In our experience, it's often a last resort in terms of the correct management of groin pain. We find it much more beneficial from the athlete to correct any underlying biomechanical issues which are at the root of the problem, and as such see symptoms settle with this. Surgery in the athletic groin is particularly fraught with difficulty, as there are a number of potentially pathological structures very close to each other, meaning a correct diagnosis can often be difficult to attain. For example, pain which may be perceived at the superficial inguinal ring may in fact be at the rectus abdominis insertion or the adductor longus origin, very easily confused unless the examiner invaginates the scrotum and palpates these areas directly, assessing from the patient's reaction whether or not these are in fact the pain generating structures. In addition to this, provocation tests such as the squeeze test and resisted double leg raise activate particular areas and do not activate others, allowing us to differentiate between them. To that end, we need to be careful about applying a one-size-fits-all approach in terms of surgery and a biomechanical groin pain. In our experience, the hip often plays a role either primarily or secondarily in groin pain. Pathology of the structure of the hip, such as femoroacetabular impingement, or secondary pathologies such as labral tears, can in their own right cause groin pain, or may in fact alter the biomechanics of the athlete such that the anterior groin structures come under increasing pressure and ultimately fail and become injured. To that end, however, it's important to note that the huge increase in the diagnosis of femoroacetabular impingement and labral tears is driven by increasing clinician knowledge and improved diagnostic techniques such as MRI and MR arthrogram. The explosion in the diagnosis of femoroacetabular impingement has led a number of people to disclaim this as a cause of groin pain and point out that in many cases femoroacetabular impingement is an exaggeration of a normal anatomical variant within the joint. Certainly in our service, we would see a high number of asymptomatic labral tears, and just because there is an abnormality or a defect on scan does not necessarily mean A, that it is a cause of the pain, or that it needs to be dealt with. Similarly, even when this is symptomatic, we often find that settling the pain in and around the structure allows us to correct underlying biomechanical issues which are causing groin pain and settle the pain completely, making surgery in its own right unnecessary. However, in a small number of cases, surgical correction of either the labral tear or the morphological, that is the shape of the bone, either the femoral head or the acetabulum, the socket of the joint, is required. When this is performed, a good deal of rehabilitation is still required after the surgery to ensure that any biomechanical deficits which occurred prior to surgery or which arose as a result of surgery are corrected, so that groin pain in its own right doesn't become an ongoing problem after the surgery. This is often seen in athletes who have successful surgery, but as a result of their surgery have dysfunctional hip flexors or lower abdominal musculature and continue to have problems afterwards. It stands to reason that the aggravating activities such as playing should be avoided when we are trying to rehabilitate from an injury. However, most of our staff have been athletes themselves and understand that in certain circumstances when your team needs you, you have to line out for them. As a result, we make every effort to try and tailor rehabilitation programs around the needs of the athlete. In some situations where the injury is bad enough, full withdrawal from activity is required. However, in most circumstances, bearing in mind that it will delay the rehabilitation progress, we do our best to facilitate people being involved with the team that they love and want to represent. This raises an important point, however, around issues such as using non-steroidal anti-inflammatories or injections to allow people to play matches and get through particularly important games. This in its own right on a once-off issue can be understood if somebody has an extremely important game to play, but it must be borne in mind this is a potentially dangerous process in that structures which are painful for a reason. They're painful because our body tells us that we need to rest this area and not continue to aggravate it. If we use either an injection or oral anti-inflammatories to blunt that pain process, we cut back on feedback and can further damage structures, sometimes beyond repair. Similarly, a group in the athletic population that we see would attend having used anti-inflammatories regularly for more than 6 months. This is a potentially extremely dangerous practice, particularly in a group who are pushing themselves to the very limits of physical activity around gastrointestinal symptoms and duodenal ulceration, but also in terms of kidney function and general health. These are strong medications, and their use to prolong playing and activity should be used with extreme care and under the supervision and guidance of your general practitioner or team physician.